A very eminent faculty, Dr. Naveed Malhotra, sir. Sir is senior professor and is heading the Pain Management Center at PGIMS, Rohtak, Haryana. And sir's area of special interest are chronic pain. We welcome you, sir. And I hand over the proceedings of the session to you, sir. Over to you.
Thank you very much. And it's a pleasure to be here Monday morning in the APPEC 2023. And I thank Dr. M.D. Kaur and other team of APPEC 2023 for the warm invitation. And it's a pleasure to introduce Dr. Sanjula Virmani, Director Professor, G.V. Pant Institute of Postgraduate Medical Education and Research, Delhi. And her areas of interest are cardiac anesthesia. And she will be deliberating on congenital heart disease and its anaesthetic implications. Dr. Sanjula Virmani, please.
Good morning, everybody. In a patient with congenital heart disease presenting for non-cardiac surgery, the anesthetic implications are based on three things. One, the nature of congenital heart disease. Secondly, the degree of cardiopulmonary impairment. And most importantly, the type of surgical procedure. So if the surgery is elective or it is less urgent and the cardiac disease is severe enough to require a surgical correction, for example, if a patient is presenting for elective hernia repair and has severe pulmonary stenosis, perform the pulmonary valvotomy first before taking up the patient for the elective surgery. If, on the other hand, if the cardiac surgery or the intervention procedure is not indicated, for example, if the pulmonary stenosis is not very severe, the patient can be optimized with medical management before cardiac surgery is undertaken with risk stratification. Now, if the surgery is of emergent nature, for example, if the patient of tetralogy is coming to you for drainage of an abscess, then the surgery should be undertaken with high or intermediate risk. But even if it is an emergency surgery, it does give us a couple of hours in order to optimize the medical condition. For example, we can correct the acidosis, we can correct the electrolytes, and we can even perform a phlebotomy in order to improve the microcirculation. The anesthetic implications can be best understood if you have a very clear knowledge about the pathophysiology of congenital heart disease and, most importantly, of the shunt lesions, left to right shunts and right to left shunt, because shunt lesions are the most commonly encountered congenital heart diseases. We have already seen that the fetal circulation is a parallel circulation in which the oxygenated blood flows from the placenta via the ductus venosus into the inferior vena cava into the right atrium. From there it gets deflected by the crista dividens into the left atrium and then is ejected into the left ventricle, and from there it comes into the aorta. Now the desaturated blood from the SVC flows into the RA, from there it goes into the RV and the PA. But because of the very high PVR, little blood enters the PA, most of it gets shunted through the ductus into the descending aorta. Now after birth, there occurs an increase in the SPR, there occurs a decrease in PVR because of lung expansion, change in arterial oxygen tension, and because of the action of certain vasoactive mediators. In the absence of congenital heart disease, a transitional period of fetal parallel circulation is transformed into the normal series circulation. The pulmonary artery pressure equals the systemic pressure immediately before birth. Immediately after birth, as ductus closes and the lungs begin breathing air, the PA pressure decreases rapidly to half of the systemic levels. Thereafter, there occurs a gradual decrease over weeks to reach the adult levels, with the result that normal PA hemodynamics is achieved. And the normal mean pulmonary artery pressure is less than 25 millimeters of mercury at rest. And if it increases to more than 25 millimeters of mercury at rest or more than 30 millimeters with exercise, it is known as pulmonary artery hypertension. At birth, both the RV and the LV are approximately equal in size and wall thickness. The increase in LV pressure leads to thickening of the ventricular wall over the first 2 years of life. This diagram illustrates the normal pressure and the saturation in various cardiac chambers. The blood on the right side is desaturated and reaches the left side after oxygenation in the lungs. the PFO and the ductus, they close, which maintains the normal physiology. Now, intracardiac shunts are the most common cardiac lesions which are seen in congenital heart disease. So the congenital heart disease is broadly classified into acyanotic and cyanotic congenital heart disease, with or without the presence of a communication or shunt between the chambers which are normally separate. In cyanotic heart disease, the blood flow across the shunt is from right to left and may be bidirectional, as seen in tetralogy, TGA, tricuspid atresia, and whereas in the left to right shunt, such as in cases of VSD, AST, PDA, the shunt is from left to right. In patients with congenital PS, AS, coaptation of aorta, no shunting is present. So shunting means there's normal systemic and pulmonary circulations are separate, and a simple shunt is said to exist if a direct communication exists between various chambers or between chambers and vessels. A complex shunt is said to exist when the associated with simple shunt is associated with an obstructive lesion. We'll first see the pathophysiology of left to right shunts in patients who have ASD, VSD, PDA, because these are most commonly seen congenital heart diseases which come for non-cardiac surgery. So this figure shows some of the commonly occurring left to right shunting of blood at various levels. And in patients who have left to right shunting of blood, there is seen a step up in saturation from SVC to PA. Now, left to right shunting of blood causes increase in the pulmonary blood flow, leading to an increase in the precapillary vascular obstructive changes, increase in resistance to blood flow, leading to pulmonary artery hypertension. Now, if this condition remains uncorrected, the pulmonary artery hypertension becomes unresponsive to pulmonary vasodilators. Ultimately, the pulmonary vascular resistance becomes so high that the shunt reverses and becomes right to left, a clinical setting which is known as Eisenmenger's syndrome. Now, clinically, on auscultation, patient with VSD will have a harsh, long systolic crescendo-decrescendo murmur, best heard along the left sternal border. P2 may be palpable and loud with narrow split. In ASD, the patient will have a wide, split and fixed second sound with soft ejection systolic murmur. And in PDA, there will be a machinery continuous murmur will be heard. A 12-lead ECG is recommended, and it may reveal right bundle branch block, right axis deviation as a consequence of atrial and ventricular enlargement. X-ray chest will relieve features of increased pulmonary circulation, chamber enlargement, which is specific to the type of lesion. For example, this is an X-ray of a 31-year-old woman with ostium secundum ASD. Pulmonary hypercirculation can be seen. There is increase in size of RA, RV, main pulmonary artery. And this is a patient of VSD. Here you can see that there is pulmonary overcirculation. There is an enlarged LA, and there is but normal or the caliber of aortic arch. In PDA, there is a pulmonary overcirculation, enlarged LA, and prominent aortic arch. If Eisenmenger develops, then there will be relative pruning of the peripheral vessels. This is an echocardiography picture of a patient with VSD. Here you can see that this is an aortic valve in longitudinal axis of the aortic valve at 120 degrees. This is the aortic valve. This is a subaortic VSD with left to right shunting of blood across it. Let us move on to the right to left shunt, which have decreased pulmonary blood flow. This slide shows the commonly encountered cyanotic heart diseases. Most commonly seen is tetralogy, tricuspid atresia, Epstein's anomaly, TGA. These are less commonly encountered diseases. Now, to understand the pathophysiology of a cyanotic heart disease, we have to understand the shunting. We have already seen that a complex shunt is one in which a simple shunt is associated with an obstructive lesion. This is the obstructive lesion which is present at the right ventricular outflow tract. This will lead to an increase in the right ventricular pressure, and this will cause a shunt to increase from right to left. If the RVOT obstruction is dynamic, as occurs in case of tetralogy, which may occur because it might increase because of sympathetic overactivity, the right to left shunting of blood increases. And this is the reason for the hypercyanotic spell, which is seen in tetralogy of Fallot. This is one of the most common cyanotic lesions. There occurs a VST. Then there is an RVOT obstruction like pulmonary stenosis, which may be valvular or infundibular, overriding of the aorta, and when right ventricular hypertrophy. Now, due to predominant right to left shunting, there is desaturation of blood, and since the obstruction is dynamic, this shunt fraction can change. This is the net result. This is a picture of echocardiography picture of a patient with tetralogy. And this is the longitudinal axis of the aorta at around 120 degrees. Here you can see that there is a mosaic pattern here which shows that there is pulmonary stenosis. That is right ventricular outflow tract obstruction. There's a small VST here. There's overriding of the aorta and right ventricular hypertrophy. Now the net result of right to left shunting of blood is there results hypoxia, congestive cardiac failure, and coagulation abnormalities. Hypoxia is the root cause of all the problems. It leads to polycythemia, increase in blood volume, vasodilatation, alveolar hyperventilation, and chronic respiratory alkalosis. All these adaptive mechanisms lead to coagulation abnormalities, increase in vascular resistance, and they impair the global ventricular function. Chronic hypoxia causes polycythemia, which leads to peripheral sludging of blood. And this causes an increase in the intravascular stasis and thrombosis, followed by a state of hyperfibrinolysis due to decreased clotting factors and decrease in the number of functional platelets. The vitamin K dependent coagulation factors also decrease, such as factor 2, 5, 7, and 9. This occurs because of hepatic dysfunction secondary to cardiac failure. Now, the coagulation abnormalities can be corrected by replacement of coagulation factors, correction of anemia, phlebotomy in order to improve the microcirculation, and also we can add administration of vitamin K. Now let us come to the anesthetic management of congenital heart disease. We will first see the anesthetic management of patients who have left to right shunt, followed by patients in whom there is right to left shunt. A preoperative assessment and pre-medication will be similar in both types of shunt cases. A good pre-operative assessment is essential in order to determine the physiological status of the patient. This should include recording of height, weight, and a thorough physical examination, and all current medication that the patient is receiving. Blood investigations such as hemoglobin, coagulation profile, renal function test, liver function test, blood grouping should be done. A physical examination should include blood pressure in all extremities, baseline oxygen saturation in all limbs, and the effect on oxygen saturation due to exercise. Edema, cyanosis, murmur, crackles, all should be taken note of. Investigations such as X-ray chest, recent echocardiography, MRI reports should be reviewed. And if the patient is receiving any pulmonary artery hypertension reducing drugs, they should be continued perioperatively. Pre-medication, a good pre-medication is very important. It reduces anxiety. It makes parental separation easy, especially in case of children. It also reduces the catecholamine release, and it helps in smooth induction. It also reduces the chances of hypercyanotic spells in patients who have tetralogy. Hypoventilation, hypercarbia should be avoided. Pulse oximetry should be monitored after pre-medication. The choice of drugs includes midazolam 0.5 mg per kg orally or 0.05 to 0.2 mg per kg intravenously. Triclofos can be given orally in a dose of 50 to 70 mg per kg body weight. Ketamine 1 to 2 mg per kg IV or 5 mg per kg orally if there is no IV access. In managing patients of left to right shunt lesions, we know that the patients are prone to develop URI, and this should be treated adequately before surgery. That means the patient should be maximally decongested before taking up the patient for any kind of surgery. The preoperative fasting time should be minimized and adequate hydration should be ensured. In small children, there are psychosocial considerations and they should be discussed with the parents. The risk of paradoxical hair embolism should not be forgotten. Care should be taken to de-air the lines properly. Now, endocarditis prophylaxis should be undertaken as per the institutional protocols. Most patients with left to right shunt tolerate surgery and anesthesia well, unless pulmonary artery hypertension is present. The anesthetic goal is directed towards decreasing the shunt flow, maintaining the cardiovascular respiratory stability, and providing adequate tissue perfusion and oxygenation. And while following all these goals, we have to minimize the left to right shunting, and this to minimize the left to right shunting, we have to decrease the SVR, maintain adequate preload, avoid any increase in pulmonary artery pressures such as hypoxia, hypercarbia, acidosis, and if there is presence of pulmonary artery hypertension, pulmonary vasodilators can be used. In the wake of pulmonary artery hypertension, a good level of sedation and analgesia is necessary. We have to avoid hypercarbia, hypothermia, acidosis, use pulmonary vasodilators like nitroglycerin, nitroprusside, prostaglandin, sildenafil. Nitrous oxide should be avoided, and we should consider elective postoperative ventilation. A few words about Eisenmenger syndrome. We've already seen that in the pathophysiology of left to right shunt, how shunt reversal can occur due to suprasystemic pulmonary artery pressure and long-standing pulmonary artery hypertension. This is generally seen with ventricular level shunts, and the patient may present with central cyanosis, dyspnea, fatigue, hemoptysis, syncope, right-sided heart failure. And pulmonary vasodilators should be used in symptomatic patients. Now, fixed pulmonary vascular resistance, it precludes rapid adaptation to perioperative hemodynamic changes, and changes in SVR are mirrored by changes in the intracardiac shunting. So any decrease in SVR will be accompanied by an increase in right to left shunting and decrease in the systemic saturation. Now, general anesthesia is generally used because of the hemodynamic maneuverability is better with general anesthesia, and it should be the preferred technique. However, regional anesthesia too has been used successfully, but the local anesthetic should be delivered slowly in incremental doses with close monitoring of the blood pressure and saturation. Currently, the pulmonary vasodilators which have been approved belong to 4 classes: phosphodiesterase 5 inhibitors such as sildenafil, endothelin, receptor antagonists like bosentan, prostacyclin like iloprost, and all these can be used for in the presence of pulmonary artery hypertension. Surgery should not be performed if the PA systolic pressure is more than 2/3 of the systemic, or if the pulmonary vascular resistance is more than 2/3 of the systemic, or there is a net right to left shunt in the wake of lesions which are predominantly with left to right shunting of blood. Now let us come to the anesthetic goals that are seen in patients with left to right shunt lesions. The patient should be pain-free and asleep. There should be maintenance of hemodynamics, and we have to minimize the right to left shunting by avoiding any sudden decrease in SVR or increase in PVR, avoiding any adrenergic surges, and if it does occur, then we can use beta blockers like esmolol. All intravenous agents can be safely used. Morphine, fentanyl, midazolam, because all of these will cause decrease in SVR. So it is not the type of the drug, it is the rate and the dose which is administered which is more important than the drug itself. They should be given in small incremental doses with careful monitoring of the blood pressure and the saturation. Inhalational induction can also be used. Sevoflurane, halothane can be used, but it may prolong because of the right to left shunting, but this is rarely a problem clinically. Now, the need for invasive monitoring depends upon the nature of surgery and the underlying cardiac lesion. There should be no central lines in patients who have already got a cavopulmonary connection such as Fontaine or Glen. Arterial pressure on the contralateral side should be used in patients who have a VT shunt existing, and we should be aware that capnography will underread the PaCO2 in the presence of right to left shunt. T can be used in order to aid in the hemodynamic management. In the presence of a hypercyanotic spell, if it occurs intraoperatively, this can occur because of because of the presence of dynamic RVOT obstruction. And this may increase due to any decrease in SVR or because of decrease in the systemic arterial pressure. So if this does occur, then we have to give beta blockers like metoprolol, esmolol, and we can also give a small dose of noradrenaline in order to increase the SVR. So this to end all the details that we have studied till now. This is a cardiac grid which you can find in any of the standard textbooks, and it summarizes the pathophysiologic goals, which is choice of anesthetic drugs that can be used to achieve the goals that we have just covered. So pregnancy in heart disease is a separate lecture because of the implications. In the presence of congenital heart disease, the patients are counseled against becoming pregnant because there is a high chance of complications with abortion rates of around 43%, PPH 50%, arrhythmias 29%, and heart failure can occur, especially between 23 to 30 weeks and at the time of delivery. So delivery has been safely conducted using neuraxial catheters, but because of easy maneuverability of hemodynamics, general anesthesia is preferred. Thank you.
Thank you, Dr. Manjula, for an excellent lecture. I can say that you had made it appear so simple and explained it very nicely to all the delegates that I myself was enjoying listening to you. And still there are some questions. We can take it up now or at the end of the session.
So we'll take